All right, so the topic tonight is the differential impact of controlled ovarian hyperstimulation on live birth rate in fresh versus frozen embryo transfer cycles. That's a huge mouthful. So in English, what that means is there a difference with the dose of your stimulation, total dose, between fresh and frozen on the impact that it has on the cycle, and is it better to do a fresh or a frozen, and should you keep your doses lower or higher, and so on. And they also actually looked at duration of stimulation, which we've reviewed previously and shown to be important, and many studies have. So the authors kind of cite a number of important studies here, and they say a lot of single center studies have shown that a long ovarian stimulation, especially more than 13 days, is detrimental with reduced pregnancy rates and live birth rates. And so we knew that. We've presented that on the show here. And a lot of people think that that's partially related to the high dose of gonadotropins that are used. So if you're using a very high dose, it's normally going to go longer as well, because it probably means the ovaries are weaker, so you need more stimulation to get the same kind of growth rate. And as a result, they're thinking that the success rates are not quite as good. They also say that the prolonged stimulation and the high dose of gonadotropins may impact the quality of the eggs and the embryos, and there are multiple studies that have shown that, about 7 in total that they've referenced here. So these guys wanted to look at a really big population and determine if that held true. So they have something in the US called SART, which is the Society for Assisted Reproductive Technology. And this is an agency that all US IVF centers must report their data to. And so they report their data to that center, they compile it for the whole country, and then people use that data to do research. So these guys took a fairly old population, 2014 to 2015, and during that time looked at 14,866 cycles that were fresh, 2,964 cycles that were frozen. Their criteria were that at least more than 90% of the embryos were blastocysts, and the patients ended up being relatively good prognosis patients because of that. So they really kind of looked at all of the different aspects to kind of get this to be a reasonable population of patients. So I'm just going to share the study with you. If you're watching on anything but Instagram, as usual on Instagram, it's impossible to follow. But I will go over the data with you here. Okay, so in the first table, the important thing you can see is that almost everything is statistically significant between the fresh and frozen group. But it's not really clinically significantly different. And the reason for that is anytime you're dealing with numbers in the thousands, even a small difference is statistically significant, but it's not actually clinically relevant. So for example, the difference in BMI between the two groups was 25.6 in the fresh, 24.8 in the frozen. Statistically significant, highly, but not clinically relevant. So that was all really true until they got down to diagnosis. When you looked at diagnosis, more people in the frozen group had PCOS, and that was significant, 26.8% versus 21.2%, so about a 5.5% increase. And then the same thing was true with AMH. They had a higher AMH level in the frozen group versus the fresh group. And then, of course, they had a higher yield of eggs and a higher yield of embryos in the group that was frozen. Now, interestingly, they had a very small difference in the spontaneous miscarriage rate in the fresh versus the frozen, with the fresh being a tiny bit less, 7.4% versus 10.4%. Live birth rate was clinically the same, and actually statistically the same too, 45.1% in the fresh, 46.6% in the frozen, and that was not statistically different between the two groups. So you can see all that here in the study. Anything that's less than 0.05 is significant. So the first table they looked at was table 2, and in table 2 what they are looking at was a comparison of where does the total dose of gonadotropins that you use in your IVF cycle fall in relation to the outcome. And if you look at less than 1,000, 1,000 to 2,000, 2,000 to 3,000, and so on, with greater than 5,000 being the final group, the success rate decreases as you go up in dose. So at the less than 1,000, those patients had a 48.5% success rate with fresh and a 50% success rate with frozen. But when you get into the, for example, 3,000 to 4,000 group, it's now down to 43% in the fresh and down to 42% in the frozen. Go up over 5,000 total units, and that's a lot, so you're using at least 500 units a day. It's 33.9% in the fresh, 37.7% in the frozen. So just to recalibrate that for you, if you're on Instagram especially, starting point was close to 50% or at 50% for the ones with the really low dose, and when you're getting into the really high doses, 33% and 37% fresh and frozen respectively. So a big difference in success rates, very highly significant. They did the same thing for duration of stimulation and essentially showed the same thing in both the fresh and the frozen groups. When you had a very short stimulation, you had a 47% success rate, 50% in the frozen group. And then it hovered kind of close to that, but then progressively drops off a small amount as you go up in your dose, suggesting that there may be an impact on the duration. Now, interestingly, in contrast to other studies, these guys used greater than 12 as a group. So this would be 13 days and more, whereas many of the studies have looked at greater than 13 days. And we certainly never go 13 days because there are enough studies that have shown that it is detrimental going that long. When you look at further evidence on this, you get into table 3, they then said, well, wait a minute, maybe there's a whole bunch of factors that contribute to this and are skewing the data so that we're not actually getting a clear picture here, because it's fine to find an association, but what if there are factors contributing to that association? Age, BMI, you know, the dosages or the types of medications that are being used. What about your diagnosis? So they actually mixed all of that in and then came up with this table 3. And this is for live births after a fresh in vitro fertilization embryo transfer. So they did their cycle and they put the embryo in a fresh cycle right after they had made the embryo. So these are not patients that had them frozen. These are patients that went directly into a fresh cycle. So what they showed here was that there was a difference in the body mass index, first of all, between success and lack of success. And if you look at it right here, there's about almost a 9 to 10% decrease in success for every unit increase in body mass index or a body mass index over 30. So you are seeing a decrease in the success rates when your body mass index is higher. When you move further down in the data here, the days of stimulation was actually not significant. So when they compared less than 8 days, 9 days, 10 days, 11, 12, and greater than 12, they actually did not see a difference in the groups. So they're not seeing a difference in the duration when they're controlling for the dosage of the medication. But when they controlled for the dosage of the medication and the duration and all those other things, they do see a difference in success rates that's quite significant. So when you have a dose less than a total of 2,000 international units of the drugs, you had your highest success rate at about a 27% increase compared to the patients that were taking more than 5,000 units. So you got almost a quarter to a third higher success rate in live birth with a fresh transfer if your dose is kept lower. 24% if your dose was between 2,000 to 3,000, almost 5% if your dose was 3,000 to 4,000. But once you're getting over the 4,000 range, you're really dropping off significantly and seeing a significant decrease. There it was just 12% higher, and once you're over 5,000, that's the reference. So you're actually showing that all the other ones were a much higher success rate. Now the neat thing about this is what happens when you do a frozen embryo transfer. So when you do a frozen embryo transfer, the only thing that turns out to be significant is your age, which definitely has an impact, small but nevertheless significant. Your diagnosis of diminished ovarian reserve had a big impact. There was about a 30% decrease in success if your diagnosis was diminished ovarian reserve. And then when they looked at the days of stim and even the total dose, they actually are not seeing a difference in that group. So everybody's saying, well, why? That doesn't make sense necessarily. So the question is, where is the impact of that high dose of gonadotropins? Is the impact on the egg and the embryo, or is the impact on the lining of the uterus? And maybe that's why it's different in fresh versus frozen. And the answer is it has to be more in the lining than on the egg or the embryo, because in a fresh cycle, you're seeing a difference, but in a frozen, you're not. If the impact was on the embryo, it's not like freezing and thawing it is making it better. It's not going to have any alteration in the embryo quality at all. If anything, potentially it might make it worse. But on the endometrium in a fresh cycle, if you have super high levels of estrogen, you're overdriving the endometrium, and we know that that can have a detrimental impact. So if it's having a detrimental impact, that could be very significant, and maybe why, when you're going to the frozen cycle, you're doing a much better sort of cycle, you're getting better results, because at the end of the day, you're going to see that those patients will have less impact on the alterations, and we're talking about biochemical alterations, in the lining of the uterus. They're actually going to have a much more natural kind of level of everything in there, and as a result, the embryos have a much easier time sticking than they would when you've got these supercharged levels of estrogen in the endometrium, and now it's really being overexposed. So the authors basically say that the dosage is important, but only if you're doing a fresh transfer. So if you're going for a fresh transfer, you do not want to be on a super high dose of gonadotropins. You actually want to stay under 5,000, preferably even under 4,000 total. What does that mean in actual numbers? You probably should limit your total level to 300 if you're aiming for a fresh transfer. With a frozen, it doesn't make a difference. It's perfectly fine to go higher. But if you're aiming for a fresh, which we rarely do these days, you definitely want to keep your doses lower. That will give you your highest success rate, and that's where you want to be. So do not let people give you too much in terms of meds. And I would still advocate for keeping your cycle length shorter, which also has to do with the duration and the dose of the meds. You're not going to get into the 5,000s usually in terms of gonadotropin dose unless you're either taking super high doses or you're taking lower doses, but for a very long time. And so it's hard to kind of fully tease those apart. You would probably need an even bigger study to see if that was an impact factor or not. But we definitely recommend keeping your cycle length not too short, so it should be more than 8 days and not too long. We stop maximum at 12. If you're going past 12 days, the egg quality really is never very good. So you need to be super cautious. So is it fact or fiction that your ovarian stimulation dose has an impact on your cycle? It's a fact with fresh cycles, and it's a fiction with frozen cycles. So with a fresh cycle, if that's your target, and usually it isn't these days, but if for you it is, you want to make sure that you are keeping your dose reasonable. And if you are doing a frozen cycle, you want to make sure that you are just getting the best stimulation for you, but keep it a reasonable duration for sure. So thanks for joining us for the fact or fiction portion of the show. This will be up on our YouTube channel, youtube.com/Dr. Victory, Dr. Victory. We have many of our other episodes there, as well as some informative videos on infertility. We have one on our saline infusion sonohysterogram. Lots of great material there for you to review. And of course, if you have any questions about anything, don't hesitate to reach out to us.